This is a session that is diabetes and wound health, pathophysiology, regulating wound healing by growth factors. My name is Larry Lavery. I'm a podiatrist in the Department of Plastic Surgery at the University of Texas Southwestern Medical Center. And the other speakers that are going to be joining me on this topic are Michael Meier, who's a podiatrist and the director of the Lower Extremity Wound Clinic at the Cleveland Clinic, Donald Miller, who's a senior epidemiologist at the Center for Healthcare Organization Implementation Research and an associate professor at Boston University, and Susie Seaman, who's a nurse practitioner at the Sharps Reese Steele Wound Clinic in San Diego. So this is a list of our disclosures for this session. So there's a couple objectives for this workshop session. The first is to review the physiology and pathophysiology of wound healing and diabetes, to summarize keys to the diagnostic workup for patients with diabetic foot ulcers, to examine the role of growth factors as an evidence-based biologic therapy for treating diabetic foot ulcers, to summarize late-breaking safety data on adjunctive therapy based on platelet-derived growth factor to heal diabetic foot ulcers, and to discuss the implementation of the basic tenets of proper clinical patient-centered care in the management of diabetic foot ulcers. So that's a busy agenda for a short period of time. So I'm going to start talking about the etiology of diabetic foot ulcers and kind of the tenets of basic wound care, which you all have probably heard over and over and over again. I know I've seen some of this information in other people's presentations, but I think it's important, and I think that a lot of it is still missed. I think the standards of care are still, I get referrals from physicians from hours away in West Texas that they just miss kind of the tenets of basic wound care. So Paul Brand said about the neuropathic foot that the whole problem is really one of mechanics and not of medicine. So this may be an oversimplification, but I think this is one of the pivotal aspects of diabetic foot wounds. Is there's a biomechanical component. If you ignore, you can put $50,000 of bioengineered tissue and stem cells and do whatever you want, and the patient is still going to ulcerate because part of the underlying etiology is the mechanics of the foot. Paul Brand also said there's no medicine that's worth walking to get for a foot ulcer. So this is an example of a patient that has dislocated metatarsophalangeal joints. You can see how deformed they are. They correspond to these extremely high pressures on the ball of their foot. You have to address their mechanics if you're going to heal this person. So many people with diabetes have unrecognized injury because they have sensory neuropathy at the site of moderate or high pressures that contribute to skin breakdown. And again, the seminal work, the person that really brought this to us was Paul Brand and his group from Carville, from his work in people that had neuropathy from leprosy. So this is my example of the person on the right that has a nice, beautiful, straight foot with a normal alignment of their metatarsals and the metatarsophalangeal joint, and then my nice, deformed person with diabetes at the bottom that has this dislocated metatarsophalangeal joint. Instead of being straight, it's severely dislocated, and this spot correlates to this really high peak pressure, which correlates to the site of their ulceration on the ball of their foot. So, it's usually there's usually an obvious mechanical deformity, or sometimes there's a limited joint mobility of the ankle or subtalar joint or metatarsophalangeal joints that you have to evaluate their range of motion. It's not all as obvious and as structural as this example. So this is an example this is looking at peak foot pressures in people with diabetes. So the red curve are people that have neuropathic foot ulcers, that develop neuropathic foot ulcers from a large diabetes cohort study. And the yellow curve, or the yellow line, are people that just have neuropathy with loss of protective sensation. So as you can see, there's this beautiful bimodal distribution, but there's also a huge area of overlap. And if you look at this and put it in a receiver-operator curve, the ability to predict who's going to develop an ulcer just based on neuropathy and pressure is about the same as flipping a coin. It's not, we use this in the disease management model thinking we could identify the people who are really at high risk, and we stopped doing it because it didn't really change our physical exam findings, and it takes a lot of time to implement this. So it's more than just peak pressure. It's probably a combination of pressure and shear, which we're still not able to measure well, but also the patient's activity level. So if you have a patient who takes 200 steps a day as opposed to 2,000 steps a day, their cumulative stress on their foot is going to be dramatically different. It's one of the beauties of some of the immobilization techniques that we use because it changes their activity as well as their pressure. So these are the basic tenets of good wound care, the standard wound care. Debriding wounds to remove necrotic tissue, paying attention to infection control, offloading to reduce repetitive stress and decrease people's activity, and evaluation of peripheral vascular disease with appropriate referral. So, this is, part and parcel of many, many presentations a day. Some focus on all of these, some just pull out little pieces of this. So first I'll talk about debridement. And I think there's a growing body of work about the importance of debridement. Almost all of it is based on post hoc analysis of phase 3 randomized clinical studies, or there's some new data that looks at databases from wound centers. But so the rationale is really to remove this dead tissue, which is just a barrier for growth factors and an opportunity for bacterial growth. Once you remove this necrotic tissue, you remove the senescent cells, you remove the bioburden, if you will, and you provide a bleeding base. So you take this chronic wound and you create an acute wound. So you start stimulating that cascade of growth factors again where it was stalled in this environment. I'll talk a little more about offloading because I think this is a pivotal piece of this puzzle. So this is our guy from the first slide with dislocated joints. And if you look at this gentleman barefoot in the gait lab, man, he has high pressures all the way across the ball of his foot because his toes are all dislocated. You can't see any of his toes, and he's lost his second toe. When you offload this person, you get this dramatic reduction. Now, you also change his gait. You change his gait from sort of a propulsive gait to a really apropulsive gait because he has a cast. He can't bend his ankle. He can't bend his subtalar joint, and he has a cast heel. So it's like walking on a peg. So you change his activity, you change his loading patterns, and you allow this tissue not to be disrupted so it can heal. So if you look at, so this is kind of a accumulation or consensus of a lot of data. So if you look at the change that we get with peak pressure, with activity, and the proportion of wounds that heal, they are related. So if you take my patient here that is just in their canvas Oxford shoe, their boat shoe that they walked in clinic with, if you put them in therapeutic shoes, something with a custom-made insole, you're going to reduce their pressure by 10 to 20% on average. And probably a third of people, you're going to increase their pressure. You're not going to have a decrease. They're going to take about 1,500 steps a day. American Heart Association says you should take 10,000 steps a day. And 20% of people are going to heal in 12 weeks. If you put them in a removable cast boot, you're going to reduce their pressure 72 to 85%. They're going to take half the steps that they take in the shoe. They're going to take 770 steps a day with a huge variation around the mean because some of our patients are still really motivated to walk. And 52 to 85% of those people are going to heal in a 12-week time period. If you immobilize people in a cast, you can, in many cases, eliminate their forefoot pressure completely, especially if they can tolerate a cast heel. And you can remove 79 to 85% of the pressure at their ulcer site. They take 600 steps a day, and 74 to 95% of people are going to heal in 12 weeks. So it's a combination of these factors, and it still looks like immobilizing people in the cast is the best opportunity to accelerate their healing if that's possible. There's not much information about what happens on the cellular level with a cast, but this is now a relatively old paper from Alberto Piaggesi, who's an endocrinologist from Pisa. And so Alberto looked at two groups of people, patients that were immobilized in the total contact cast for 20 days, and then he excised their ulcer. So this was an endocrinologist excising people's ulcer, and then people that weren't immobilized and had their ulcer excised. And then he looked at the histology. So if you look at the histology of people that had no offloading, they have more hyperkeratosis, more fibrosis, and more inflammatory cells than people in a cast. And the people in the cast have more capillary budding and a significant increase in granulation tissue. So it looks like pressure not only has a direct effect on the ulcer, keeping it open, but it also is a source of repetitive mechanical trauma and inflammation. So after you take the pressure off, these DFUs look more like an acute wound than a chronic inflamed wound. So still more work needs to be done so we understand this process. So perhaps that's on the horizon. Is bacterial load important in patients? I think for a long time we have been told you can't see this. It doesn't look like it's infected, but there's bioburden there. And now you hear there's not only bioburden, but there's biofilm that you can't see, and you need to use this dressing. That's why your patient isn't healing. What is reported in DFUs and what's reported in VLUs is contradictory. There are a few studies that say this is important, and there's, I think, newer, better studies that say, no, it's not. So this is one of the older studies. Let me show you. So this is one of the older studies that looked at 32 patients with neuropathic foot ulcers. So this is the problem I have with these patients. 83% received antibiotics, but not all the cases of the patients that received antibiotics would really have fit the definition of being infected by conventional criteria. So, it's like, yeah, I think you need antibiotics to heal, even though you don't look like you're infected. They obtained wound fluid for analysis, and they looked at the bacterial load and looked at the CFUs and healing. The wound healing rate over the following 28 days was calculated, and what they found was, so this is their little trajectory of their log CFUs, and what they found was wound healing had a strong inverse relationship with the log CFUs. So the higher your CFUs, the less likely you were to heal. For every log order of CFU increase, there was a 44% delay in wound healing. Okay, so this is relatively old. There's not much in the DFU space until recently. So this is a nice body of work that was funded by NIH from Sue Garner. She looked at 77 DFUs that were treated with a TCC and debridement. And I think this is the way you need to evaluate this. They have to have the best standard of care. And I think that's what this study provided. 84% of people healed. That's what the literature says. That's about the sweet spot, what lots of other people report for immobilizing patients in a total contact cast. They healed from 2 to 26 weeks, and the median was 4 weeks. 5 people developed an infection, so only 6.5%, which is consistent with what is reported in TCC literature. There's fewer infections when you immobilize people and protect your wound from the patients and all the other healthcare providers that want to touch it and look at it. Bioburden dimensions. So she looked at a couple different factors. She looked at microbiological load, microbiodiversity, so differences in bacteria, and they were not associated with wound healing. What was associated with wound healing were the traditional things that other people have reported that are associated with wound healing. Ulcer depth, ulcer duration, and surface area. So when you put this in a regression analysis, bioburden doesn't come out. So I think this is a well-done study. I think the standard of care was high, and it was a robust analysis. So these findings really support the recommendations of the Infectious Disease Society, the International Working Group on the Diabetic Foot Infection panel, who recommend that you not take routine cultures of wounds that aren't infected. So part of the standard of care is to look at patients and correct the underlying condition if that's possible. So pay attention to clinical signs of infection. Consult the vascular surgeon or your interventional radiologist or interventional cardiologist, whoever you live with that can help revascularize your patients. Address their glucose control and their burden of disease in general, their hypertension, their obesity, their diabetes. I think offloading is a pivotal part of this. Maintain a moist wound environment, remove infected and non-viable tissue with aggressive debridement, and I think that will help provide a good environment to stimulate the endogenous growth factors and protect your patients from becoming infected. So even when people get standard wound care, when you can check off all of these boxes, the proportion of people that heal in 12 or 20 weeks is still poor. Probably the best paper on this was that I still love. It's probably a decade old now. Was the paper by Dave Margolis that looked at the treatment outcomes in the control arm of, at the time, 3 phase 3 PMA level clinical trials that showed people that received standard wound care in the control arm at 12 weeks, only 24% of people healed, and at 20 weeks, 31% of people healed. So pretty abysmal results. I mean, the bar is low, I think. So I think even when you're doing a really excellent job, there's room for us to improve this process. So to summarize, DFUs often occur at sites of high pressure or stress or shear in patients with sensory neuropathy with loss of productive sensation, so they don't feel that they're being injured. The basic tenets have to be addressed before you think about doing anything else. You have to debride the wound. You have to make sure that you optimally offload that person, based on the best you can do. And I think we have limitations with, what people can tolerate, what they can afford, what insurance provides. You have to pay attention to local signs of infection, and you have to evaluate and refer people for peripheral vascular disease. But still, even when all these are done, there's more for us to do, and I think it's why there's such an interest in advanced wound products. There's such an interest in is biofilm important? Can we address it? And other important components of this. So next, I'll turn this over to Dr. Meier to talk about the diagnostic workup of diabetic foot ulcers.
Thanks to Dr. Lavery for an easy setup. He covered a lot of the basic information and did it so nicely and elegantly. But the job I've been asked to perform this morning is to talk to you about the diagnostic workup of the diabetic foot ulcer, so specific focus on the clinical evaluation. So that said, we certainly have to start on a very superficial level when it comes to looking at some of these patients. Certainly systemic factors such as glycemic control, comorbid conditions, body habitus, size, etc. Their functional level. Are they in fact ambulatory? What's the support structure in the home? Some of these non-tangibles make a big difference, obviously, in terms of ongoing compliance or non-compliance with wound care instructions. And then certainly transitioning over to the physical exam side, looking at factors like Dr. Lavery illustrated, that of perfusion, infection, offloading, edema control, and certainly moist wound healing, which we know is widely supported in the literature. So that said, we'll look at some of these a little bit more closely. So when it comes to perfusion assessments, by no means should we start with the physical exam. You start with a history, obviously. And certainly if asked the right questions, you'll get the answers you seek. So finding out relevant, pertinent points such as whether or not the patient has a history of coronary or known peripheral disease, hypertension, stroke, TIA, etc. Are they in fact smokers? We know the data is abysmal for healing with smoking patients. Do they exhibit overt signs of PAD, such as claudication or rest pain? Have they had previous ulceration? And if so, how were they treated? What happened? What was the outcome? Have they had amputation? And then, in fact, do they wear some type of orthoses or prosthetics? And certainly, have they had any interventions or revascularizations? When it comes to the physical exam itself, we certainly start with the skin. We can look for atrophy or thinness, temperature differences, not only from one limb to the next, but regionally from one area to another. Certainly color changes become readily apparent in patients with profound peripheral vascular disease with dependent rubor and elevation pallor or acrocyanosis of the distal periphery. And when it comes to evaluating the ulcer itself, we all know to document things such as size, location, depth, borders, and peri-ulcer skin characteristics. Obviously, there are classic findings when it comes to those with known vascular disease. In terms of perfusion evaluation, it's oftentimes a stepwise approach, and we certainly start with a comprehensive pulse exam. I think sometimes as podiatrists we're remiss to look at more proximal pulses, so it's important to do a complete pulse examination, including popliteal and femoral pulses. In the absence of pulses or abnormal pulses, certainly handheld Doppler or ABI is appropriate. and in some cases then segmental pressures and other means of evaluation such as arterial duplex ultrasonography or transcutaneous oximetry. This is by no means a complete list, but we'll take a look at a couple features of these. So certainly the ABI is nothing new to this audience. It's been around for a long time. It's simply a measure, a ratio of the highest systolic ankle pressure over the highest systolic brachial pressure. And we know that this scale that's reported on the slide is fairly widely accepted. It's been around. The data goes back a number of years, but 1.3 to 0.9 being normal, 0.9 to 0.7 mild arterial disease, 0.69 to 0.4 moderate, and below that severe disease, or the definition of critical limb ischemia. We also know, though, that an ABI above 1.3 is abnormal, and in fact, historically we would say is just consistent with calcified vessels. But we know now that that's probably not entirely the entire truth, rather, and that in addition to the calcification of vessels, there's also some degree of stenosis. So we can't assume that it's just a hard-walled vessel, but there's probably also some occlusive component to it. Again, critical limb ischemia being an absolute ABI of less than 0.4 and absolute ankle pressure of less than 50 to 70 millimeters of mercury. It's also probably one of the most important things to remember. An ABI is a very useful screening tool, but it's just that. It's really an inadequate measure of distal perfusion. So the ABI tells you about perfusion largely in the leg. It can give you some hints as to what's going on in the foot, but we now have much more sophisticated modalities to look at the distal periphery to find out perfusion within the foot itself. One of those is the toe breaking index, and this is certainly appropriate in patients with those calcified vessels. You can see even on a plain film radiograph, diffuse calcification of the arterial tree, so making that pulse examination incredibly unreliable. So it's very helpful to use measures such as TBI in this type of circumstance, and we say that a TBI above 0.7 is normal, and the definition of critical limb ischemia is an absolute toe pressure of less than 30 to 50 millimeters of mercury. Now, depending on your patient and index of suspicion, you may order things like segmental pressures or PVRs. These are pressures and plethysmographic waveforms that are used for analysis of the vascular tree in the lower extremity, and it really compares blood pressures at multiple sites on the legs. And we say that a segmental drop of 20 millimeters of mercury or greater from one segment to the next or compared to the contralateral limb is consistent with obstruction or disease at that level. And I'll show you a slide in a moment to illustrate that. When it comes to the distal periphery, we can take a look then at transmetatarsal, toe, or digital PPG tracings to help evaluate small vessel perfusion. So what's pictured here is an example of a fairly classic PVR study. You can see it's a little bit flipped. On the left-hand side of that is the right leg, and on the right-hand side is the left leg. But you can see there's a clear difference between the two. But again, this study helps us to localize the level of disease. So instead of just saying there's arterial occlusive disease, we can help to determine at what level that occurs in the anatomy. So classically, the blood pressure cuffs become the boundaries for those levels. So pressure gradients between the arm and the high thigh cuff localizes disease to the aortoiliac level, between the high thigh and low thigh, the common femoral profundus segments, from low thigh to calf, the superficial femoral popliteal segments, from calf to ankle, the tibiovessel or infrapopliteal segments, and below that, obviously, the small vessel segments in the foot itself. And again, in the setting of calcified vessels, such as diabetic patients or those with renal disease, we may need to use those waveforms as those pressures become largely inaccurate. And you can see there's a clear difference between the tracings and right and left legs. Here you can see a flat tracing at the right calf, indicative of distal SFA popliteal disease. Now, another measure of perfusion is that of transcutaneous oximetry. I'll just mention it briefly. Certainly, it's been talked about in other sessions throughout the meeting. But this measures the oxygen tension 1 to 2 millimeters below the level of the skin to assess the local capillary perfusion. And depending on your bias or the paper you read, oftentimes this is a tool that's used to predict candidacy for and responsiveness to hyperbaric oxygen therapy. There are other modalities that can be used as well in terms of predicting wound healing capacity, such as the skin perfusion pressure. But again, the transcutaneous oximetry has been around for a long time, and I think it's still a useful tool, at least when it comes to utilizing hyperbaric therapy. In terms of values, you can see Carolyn Fife and her group, this has been a number of years, reported normal values above 50 millimeters of mercury, that kind of gray zone from 50 to 30, and then below 40 or below 30, really, again, that critical limb ischemia. Certainly the technology has improved over the years in terms of false positives, or rather falsely elevated numbers, but it can be influenced certainly in the setting of peripheral arterial disease, but also high altitudes, pulmonary disease, causes of peripheral edema, inflammation, and then callus skin changes, such as in the setting of scleroderma, et cetera, can skew those numbers. So you have to always pay attention to those factors when looking at transcutaneous oximetry. Now, certainly another very important part of assessing the diabetic foot ulceration patient is that of infection and infection control, and some basic pearls that, again, Dr. Lavery presented in data form. But certainly we have to remember basic things like not leaving dressings in place for extended periods of time. Sometimes we're driven by package inserts and the box says it's okay to leave it in place for a week, but then the patient comes back and they have this mess such as pictured there. We really didn't do anything in this case other than just to change the frequency to more often to accommodate the volume of drainage. And in that simple change, then a week later has a very different appearance without all that accumulated debris and dried blood and necrotic tissue on the periphery. So again, paying attention to frequency of change can make a big difference in terms of reducing bioburden. Again, antibiotic therapy, a very important part of treating our patients with overt infection, and I think Dr. Lavery spoke to this, that by and large, superficial cultures really become an unreliable guide. If we do that, I think you're going to find bacteria on darn near everything, so utilize deep cultures whenever possible. And then really don't take that as just a segmented portion of the examination to correlate those studies with the clinical picture. So what's pictured here is a diabetic foot patient, foot ulceration patient. You can see they have both a primary and secondary defect, primary defect right here and a track to the secondary defect. And if we just swab some of this copious drainage there, we may not identify the true pathogens deep in the wound. So we actually have to probe this wound, take deep tissue cultures, and we actually find with appropriate imaging this extends to the bone level with osteomyelitis of the cuboid. So again, we have to take deep tissue cultures, including bone in this circumstance, to help guide therapy appropriately. We can certainly utilize advanced imaging modalities, beginning with things like simple radiographs to assess the presence or absence of soft tissue and bone infection. And what's pictured here is a patient who's had resection of the fifth metatarsal head due to pressure ulceration, unfortunately not adequately offloaded. And now you can see very clear evidence, radiographic evidence, of osteomyelitis and septic arthritis of the first metatarsal phalangeal joint. So some would say this patient's going to be relegated then to a transmetatarsal amputation due to the inherent instability of just the intermediate rays. Now, another important point of infection control in the diabetic patient, certainly in the setting of dense peripheral neuropathy, Dr. Bolton has said these patients have the absence of the gift of pain. And that's certainly the case in this circumstance. The patient presents with a non-healing partial first-ray amputation site. You can see a fairly unhealthy appearance to it, certainly has a component of infection to it. But we take a look at the radiographs to see what is, in fact, the health of bone, if you will. And you can see that there's a very nice linear cut through that midshaft of the first metatarsal, so it looks pretty good. But the patient decided to continue follow-up with the provider treating him at the time and came back 3 months later and said, you know, the chief complaint was actually that he had stubbed his toe. And he said, by the way, that pesky little amputation site, it never really quite healed, but it's fine. I'm off antibiotics. Things are good. I don't have any pain. And again, look with your hands, not just with your eyes. So there is certainly a clinical improvement with just a small residual deficit. But when we take repeat radiographs, you can see a far different picture, unfortunately, for this patient. Not only, in fact, does he have now an irregularity to that midshaft of the first metatarsal, but now also septic arthritis and osteomyelitis of the adjacent second metatarsal phalangeal joint. So again, in the absence of that dense peripheral neuropathy, ongoing infection that the patient wasn't aware of because of that absence of pain feedback. Now, certainly offloading and debridement, Dr. Lavery spoke to very eloquently. I'll just touch on a couple of basic concepts. We certainly know in the setting not only of sensory neuropathy, but these motor neuropathy components create mechanical imbalances between flexors and extensors and opposing muscle groups. And you can see various examples of digital contractures and joint abnormalities. And even with something as simple as an imbalance between flexor and extensor at the first metatarsal phalangeal joint with rather normal mid and hindfoot architecture, you can see that that simple imbalance not only has created risk of ulceration on that plantar aspect of the first metatarsal phalangeal joint, but also on the very distal tip of the toe and on the top of that interphalangeal joint if in fact the patient isn't fit with shoe gear that has adequate depth to the toe box. So certainly we worry about that sensory neuropathy, and we podiatrists say that these types of things, such as callus formation on the medial aspect of the first MPJ and then large spin callus toward the middle of the foot, is a precursor for ulceration. So we say it's pre-ulcerative in nature, and unfortunately, as we all know, these patients oftentimes don't come in until they have that classic hyperkeratotic halo, and once debrided, reveals a whole different story with full-thickness tissue loss. So in the way of patients with peripheral arterial disease, I think this is quite obvious, but unfortunately some of these patients come in, again, with dense peripheral neuropathy and ill-fitting shoe gear. You can see examples of full-thickness tissue loss on both the heel and toe, and it's important to remember not to aggressively debride these patients, in fact, until there's at least some plan in place to optimize perfusion. So again, reiterating what Dr. Lavery spoke to is making sure we have nice conversation and collaboration with our vascular surgeons, interventionalists, et cetera. And unfortunately, we can't heal all wounds, as we all know, and we do things like transmetatarsal amputations, and in some circumstances this becomes a very desirable functional foot on which to bear weight and lead life. However, at the risk of stating the morbidly obvious, don't forget about the opposite foot. Unfortunately, in this circumstance, the patient wasn't fit with appropriate offloading footwear and orthotics for the opposite foot, now with full thickness loss on that ball of the foot on the opposite side, and now is relegated to bilateral transmetatarsal amputation. So when it comes to offloading, again, a whole laundry list of things that are out there in terms of choices. Oftentimes based on ambulatory status, we can utilize foot orthotics, including the ankle or not. We can make shoe modifications. There are different pressure relief boots, wedges, braces, and advanced custom devices. Again, the gold standard being that of the total contact cast is pictured on the far right. And again, I'm not going to go into those at detail. You've heard some information. But what I'd like to conclude with very briefly is an example of a case, a 58-year-old diabetic gentleman who came in with chronic pressure ulceration in the setting of previous transmetatarsal amputation, the wound having been there for over a year. And his treatment was very comprehensive. He was not found to have any significant arterial occlusive disease. Radiographs, repeatedly so, didn't demonstrate any evidence of osteomyelitis. He had offloading with a variety of different devices, both custom and non, including serial total contact casts and a whole host of advanced tissue grafts. And this is what his foot looked like on presentation, so it has a fairly reasonable, healthy appearance to it. But again, it's incredibly important to remember to look at the whole patient, not just localized treatments according to the wound itself. And in this circumstance, it doesn't project terribly well in this light, but you can see this patient has profound concomitant venous insufficiency with deep pitting edema on the lower leg and a copious volume of drainage on that dressing. Unfortunately, over the course of the full year of treatment, no one had addressed the edema adequately so, with focus rather on offloading, infection, et cetera. So again, making sure we assess and treat the whole patient in order to facilitate healing. So I'd like to thank you for your kind attention. I'm going to turn the podium over to Susie Seaman.
It's really great to be here this morning with you and to have the opportunity to speak about something that I think is really exciting, and that's growth factor therapy. Specifically this morning, what I'm going to be talking about is the role of platelet-derived growth factor, or PDGF, in the evidence-based treatment of diabetic foot ulcers. So first of all, let's just talk about what is a growth factor. A growth factor is a complex protein released from cells that stimulate a host of different activities. I like to think of growth factors as chemical messengers. They're ways that cells communicate with each other. And so when a growth factor is released and binds to a receptor on another cell or even on itself, it stimulates a host of different things, including cell migration, called chemotaxis, cell proliferation or mitosis, angiogenesis, production and degradation of extracellular matrix. And remember, when you get production of extracellular matrix and angiogenesis, what is that? Granulation tissue. So growth factors stimulate granulation tissue formation. And then also, growth factors stimulate growth factor production by other cells. So this is just an illustration of exactly what's happening here. I like to think of growth factors and target cell receptors as kind of a lock and key mechanism. So you have a receptor on the cell surface, and then you have this growth factor, again, which is a protein that comes in, and just like specific keys fit into specific locks, specific growth factors fit into specific receptors. And that receptor, that growth factor binds to that receptor, and then it induces what's called a signal transduction pathway. What is that? Basically, what that is, it's a way of getting the message, migrate, divide, produce granulation tissue. Get that message from the outside of the cell to the inside of the cell. And once that message gets inside the cell, it induces gene expression. And depending on which genes are expressed, you're going to get some type of response. Again, be it a change in cellular activity such as migration, protein synthesis, or cell proliferation. So there are many growth factors in wound healing, and there are specific growth factor families, EGF, TGF, beta, et cetera, with growth factors, different growth factors in the particular families. Today we're going to be focusing on, again, PDGF, platelet-derived growth factor. Now, PDGF was first named that because it was first isolated in platelets. But we now know that multiple cells involved in the wound healing process release PDGF, from smooth muscle cells, fibroblasts, vascular endothelial cells. Also, macrophages secrete PDGF. And what exactly does PDGF do? Well, it's involved in every process in the wound healing cascade. First of all, it's released from platelets. Whenever you have a broken blood vessel, whenever there's any kind of trauma, surgical trauma, accidental trauma, whatever, and there's bleeding, platelets degranulate and release PDGF into the wound site. And initially what PDGF does is it chemotactically calls cells to the wound site. First cell on the scene is the neutrophil. And what is the neutrophil? It's a white cell that is a soldier against bacterial contamination. And we want that early influx of neutrophils into the wound site to control bacteria. What we see in chronic wound healing is that you tend to get too many neutrophils over time influx, and you get this kind of chronic inflammatory response. But in normal wound healing, we want those neutrophils there for a day or two to kind of decrease bacterial counts. The other cell that comes on the site is the macrophage, and many people consider the macrophage an orchestrator of wound healing because it secretes multiple growth factors to stimulate the wound healing process. And specifically in inflammation, in the inflammatory phase, macrophages secrete more PDGF, which then calls other cells to the wound site and lead us into the proliferative phase of wound healing. So fibroblasts are chemotactically recruited to the wound site. They're stimulated to divide and to start producing that extracellular matrix. The PDGF also stimulates cell synthesis of angiogenic factors such as VEGF. It stimulates angiogenesis, as I said earlier. It's very important in terms of that. So again, that granulation tissue formation. And it recruits bone marrow-derived stem cells to the wound site, as well as stimulating the transformation of fibroblasts to myofibroblasts, which is important in terms of wound contraction. PDGF is also important in terms of the remodeling phase of wound healing, where you have a closed wound, but you have a scar that needs to strengthen and improve its tensile strength. And again, it's important there because it stimulates activity of fibroblasts. So what is Bacaplermin gel? Bacaplermin gel is human recombinant platelet-derived growth factor, which is complexed in a carboxymethylcellulose gel, in a hydrogel. And basically, it's made the same way that they make humulin and other biologic products. Basically, the human gene for platelet-derived growth factor is inserted into a yeast cell, and that yeast cell becomes a factory for producing PDGF. So because it's human PDGF, it has biologic activity similar to our own endogenous PDGF that is released from our platelets when we traumatize ourselves. Bacaplermin is the only approved prescription drug indicated for the treatment of full-thickness diabetic foot ulcers with adequate blood supply. So I want to review the phase 3 trial that led to the FDA approval of Bacaplermin. This particular study was published by Wieman et al. In 1998. And some of you might say, gosh, Susie, that's 17 years old. It's still a very, very important study for a couple reasons. Now, I've been in chronic wound care, I'm going to date myself, since 1990. And in the 90s, I remember how we did wound care. We did all those basics of good wound care, which, by the way, are still extremely important, and we cannot forget them as we're introduced to new modern advanced therapies. But that's all we had. And we based a lot of our opinions about what we did on how we were taught to do it, or we did things because that's how we've always done it. Or we looked at case studies or small trials with 20 to 30 subjects. And I'm not saying that case studies aren't important. They are. They stimulate interest. But they're really not evidence. And we practiced wound care, and sometimes we still do this today, very different in how, for instance, coronary artery disease is treated, or cancer, or hypertension. Those chronic disorders are treated based on evidence and large randomized controlled trials. But again, in wound care, we do things sometimes just based on, well, I've always done it that way. And so you've heard a lot of this meeting about using evidence. And I remember when this study was published, because it was landmark for chronic wound care that we actually had a study with 382 patients, which for wound healing is huge, not huge for cardiovascular disease, but huge for wound healing. And we had a really well-designed trial showing efficacy of a product. To date, 17 years later, this is still one of the largest chronic wound healing studies published, again, in diabetic foot ulcers, but again, one of the largest ones. And so I always say we need to use this as a template when we're talking about how we study and use evidence for new modalities, because this is how it needs to be done, a large prospective randomized controlled trial. So basically, the objective was to study the efficacy and safety of Bacaplermin gel. And again, it was multi-center, double-blind, placebo-controlled. And they looked at healing rates, including complete wound closure, for a maximum duration, over a maximum duration of 20 weeks. And again, 382 patients with type 1 or type 2 diabetes with at least one full-thickness ulcer of over 8 weeks duration. And the ulcer size had to be between 1 and 40 square centimeters. Average wound size in this trial across all groups was about 2.6 to 2.8 square centimeters. Transcutaneous oxygen levels had to be greater than 30 millimeters mercury, and across all groups, the average TCPO2 was 55 millimeters mercury. And then the treatment regimen was after sharp debridement. Patients were randomized to receive either Bacaplermin gel plus good ulcer care, which included, of course, off-weighting, or placebo gel, which was that carboxymethylcellulose gel without the active ingredient, plus good ulcer care. So when they looked at the incidence of complete wound closure at 20 weeks, patients treated with Bacaplermin plus good ulcer care had a 50% healing rate versus those patients treated with just good ulcer care and the placebo gel had a healing rate of 35%, and that was statistically significant at a p-value of 0.007. In addition, what they saw is that the groups started to separate in terms of improved wound healing at about the 4-week mark. So compared to placebo gel, Bacaplermin gel significantly increased the incidence of complete wound closure by 43%. Then they looked at healing rates, the average time to healing. And in patients treated with Bacaplermin plus good ulcer care, the average healing time was 12 weeks versus 18 weeks in the group treated with good ulcer care. So on average, the healing was 6 weeks faster in patients treated with Bacaplermin. And again, that was statistically significant. So let me go through a couple case studies. This first case was a 50-year-old male with a history of type 2 diabetes. He also had peripheral neuropathy, and he had been very recently diagnosed with peripheral arterial disease. Had very recently had both his right and left external iliac arteries stented, and he had had a recent left fifth toe amputation for osteomyelitis. It was at the time of that problem that they discovered his peripheral arterial disease. He had also had recurrent left foot ulcers under the first MTP for 3 to 4 years, and the current ulcer when he came to see me was about 5 months old. He came into the clinic ambulatory in a post-op shoe with a cutout under the ulcer. Circulation-wise, post-stenting, he actually had pretty good distal flow. His left dorsalis pedis pulse was 2+. It was triphasic qualitatively with the Doppler, and the posterior tibial pulse was 2+ and biphasic. So I felt pretty good about his flow. X-ray was negative for osteomyelitis. So this is a picture of the wound on day 1, and you can see that very prominent first MTP joint. That's where the pressure is. That's where the ulcer occurs. And this, again, was full thickness. It was not, did not probe to bone, and again, no signs of infection. He had good vascular supply, so we debrided the wound. I decided I always have a long talk with patients, kind of a come to Jesus talk with not only what causes these wounds, repetitive trauma, pressure, you've heard that from other speakers, but how we get them healed. And the fact is unless they keep the pressure off this, there's nothing I can do to heal them. They have to get the pressure off. And in this particular case, I actually wanted to put him in a contact cast. He was a perfect candidate for a cast. Absolutely refused it. He said, I'm not walking around with one of those. Well, yeah, exactly. I don't want you walking. But we compromised, and he was actually this is uncommon, but he was actually someone who could truly use crutches correctly. I don't know if any of you have ever tried to use crutches. I have. It is really hard. I hurt my foot a couple years ago and was put on crutches, and I went, oh my God, this is what I've been doing to patients. This is, shortness of breath, and I'm fit. The strength you need to use crutches. But this guy really could, where that foot was in the air off the foot. And he had his wife with him, which is always very helpful because she was going to police the situation at home. And so we off-weighed him in the same shoe. I didn't put him in anything else with the cutout and used the crutches. And then that day, because, again, good vascular supply, no infection, he's been debrided, we're off-weighting him, I prescribed Bacterial that day. And it was applied to the wound on a daily basis. Just a thin layer across the wound bed covered with saline moistened gauze, left in place for 12 hours, and then saline moistened gauze alone for the second 12 hours. And so he came back 7 days later, and his wound was smaller. We have beautiful granulation tissue. We have a nice little healing edge there. Did a little bit of debridement of some callus and continued the off-weighting and Bacterial. And, of course, what I wanted to see was him coming down the hallway to the clinic with his crutches. I poked my head out the office door, and indeed he is using the crutches correctly. This is on day 17. Again, the wound is half the size at this point, filling in beautifully. We continue the Bacterial and off-weighting. And on day 27, he was almost healed. He was down to 2 by 2 millimeters. And at this point, I was afraid the wound would dry out, so I just switched him over to some petrolatum-based gauze, and he was completely healed 10 days later. He was, I then prescribed diabetic shoes, but I kept him off-weighting because I always tell patients that purple scar is like Jell-O gelatin. And if you walk on it, it's going to reopen. We've got to give that scar some time. So until he gets his shoes, it's going to take a few weeks to get those shoes. He's still off-weighted using the crutches. The second case and final case is of a 32-year-old female with type 1 diabetes. As you can see, very poorly controlled, lots of complications of diabetes, retinopathy, peripheral neuropathy, microalbuminuria. And she came in with a history of 2 left foot ulcers for 5 months. And interestingly, she comes in ambulatory wearing flip-flops, has never worn diabetic shoes, doesn't want to talk about wearing diabetic shoes. And so I already knew that was going to be a potential challenge. Dorsalis pedis posterior tibial pulses were 2+ and biphasic with the Doppler, so she had good flow. She did have clawed toe deformities. She did have decreased ankle joint mobility. X-ray was negative for osteomyelitis. So these are photos of what the 2 wounds look like, again, on the exact same foot. She had this full-thickness ulcer on her heel surrounded by callus, and then she had this wound on the tip of this claw toe. Did not probe to bone, and again, X-rays were negative. But this toe was just a little bit red, not significantly red, but a little bit red, a little bit swollen. So I went ahead and put her on some cephalexin to cover for gram-positives. I debrided, got a culture. Culture came back showing staph and strep, so she was on the right antibiotic. But again, the infection was minimal, and again, debrided her. Talked about off-weighting. With her, she wanted to use a scooter. And I really try to involve my patients in the decision about how we off-weight them. I don't care how they off-weight, as long as they off-weight, okay? And so with her, she felt that she wanted to do the scooter route, which was fine. So I just put her in a DH shoe. No, I didn't take out any puzzle pieces or anything, but just a shoe to protect the foot. And then the understanding was that scooter was used at all times. She can't get up at night without it to go to the bathroom. She has to be off this foot. And so again, she had mild infection, but nothing that I was very concerned about. So I felt comfortable starting Bacaplermin gel, good vascular supply. She's debrided, she's off-weighted. So again, that day I prescribed Bacaplermin, applied daily by the patient. I also referred her back to diabetes education and said, get back to your endocrinologist. We can't be walking around with an A1C over 12. This is an example of a knee scooter. Now, these can potentially be dangerous. I mean, how many of you have used these with your patients? The problem with them, especially the one where it's a three-wheeler with a single wheel in front, they're unstable. And the patient gets to really moving along and they hit a rock and they will tumble. And they can get a head injury, a neck injury, etc. So I always caution patients about how they have to be careful with these. They have newer ones now that have four wheels that are a lot more stable, but they still can wipe out. So, and they make big boy knee scooters now for your 500-pound patients that can be very effective. So this is an example. This is when she came back 2 weeks later. You can see significant improvements in her wounds. Her infection was gone in the toe. Both wounds are half the size that they were. We did a little more debridement of callus, continue off-weighting, and again, I'm looking to see her in her knee scooter coming down the hallway, which she was. Continue Bacaplermin, and then I put in a referral because it was going to, it takes a few weeks to get in for consideration of surgery to correct her claw toe deformities and potentially for something to improve that ankle joint mobility, like a Achilles tendon lengthening surgery. Yeah, it's not my decision. I want the podiatrist's opinion as to what this patient needs. And then I went ahead and put in a prescription for diabetic shoes, although she can't wear them until she's well healed. Came back 2 weeks later at day 28. She was completely healed. And again, these are wounds that have been present for 5 months. So we stopped the dressings, but we continued the healing shoe and the knee scooter for a few more weeks until she got her diabetic shoes. And then we have her gradually start using those diabetic shoes as she's gradually decreasing her time in the knee scooter. I continue to see these patients for a few months because I want to keep an eye on them, make sure they're not getting any new red areas, any new callus that could indicate pressure and indicate that we need to adjust those diabetic shoes. And so I'm going to turn the podium over to Dr. Miller.
Thank you for excellent background and previous talks. I'm going to address the question of safety of Bacaplermin or PDGF treatment for diabetic foot ulcers, and I can quickly go through the background since you've covered it so nicely. I just want to point out that it's an extremely common, serious complication of diabetes, affecting about 12% of the 300 million people with diabetes will have a foot ulcer. It's also extremely costly in terms of healthcare costs, mortality risks, quality of life. So we need better treatments. And as Susie Seaman discussed, Bacaplermin represents a potentially good treatment that with demonstrated efficacy. So I'm going to talk briefly about just overall safety. Trials have shown a number of adverse effects, but the only ones that are more common in Bacaplermin users have been rash at about 2%. Otherwise, the major concern is cancer promotion. There are a number of signs why PDGF may be affecting cancer promotion. It's a proto-oncogene. It's overexpressed in human tumor cells. It stimulates infiltrating fibroblasts, and it may affect signaling and growth promoting in certain forms of cancer. At the time of market entry, 2 trials were followed for an additional 20 months to identify potential cancers, and over the 20-month period, 9 cases were found among 291 exposed Bacaplermin people compared to 2 in the 200 placebo, which is an excess rate but not statistically significant. There was really no consistent signal, but nevertheless it was a cancer signal at the time of market entry. So post-marketing studies were then required by regulators at that time. It was deemed impractical to do trials for safety of cancer given the size and the length of follow-up. So these are post-marketing observational studies. The first of these was conducted by I3 in 1,622 Bacaplermin users, 2,109 comparison patients. It's a United Healthcare database. It's a private claims database. They were followed for an average of 20 months with cases confirmed by medical records and the National Death Index. And the results are shown here, which is overall there was really no evidence for increase in the risk of incident cancer, incident skin cancer, or cancer deaths in the Bacaplermin group. However, when they analyzed the results by dose, they found in those in the highest dose, 3 tubes dispensed, a significantly increased risk of cancer death. This was based on only 4 cases. But nevertheless, it led to an FDA warning label, as you can see here, warning of the possibility of cancer and warning against using the gel in patients with prior cancer. So this led to a decline in the use of Bacaplermin, to restricted use guidance, and also the call for more post-marketing studies. There was continued follow-up of the I3 data, and over a period of 9 years, this estimate of risk with high-dose use went down to 2.4, but nevertheless, more research was clearly needed beyond this one study. So our group conducted the second study among national veterans in VA care over this period of time. We identified patients who had diabetic foot ulcers and no prior cancer, and followed them up through 2009 with up to 11 years of follow-up. So Bacaplermin initiators were compared to matched comparators, and then over follow-up, we identified incident cancer, which we also confirmed with charts and pathology reports, and then cancer deaths identified through the National Death Index. In addition to the overall sample, we had about a 25% subsample with additional information on important cancer risk factors, smoking, alcohol use, etc. This is important because of the possibility that these could confound or otherwise confuse the findings. So this is how the sample was derived. Among the almost 9,000 VA patients, we identified almost 11,000 who had received Bacaplermin, and after a number of exclusions, ended up with the most important of which was to exclude all of those who had prior cancer indicators, that is, evidence of potential cancer. We ended up with a final sample of 6,429 and matched them 1-to-1 among comparators who did not use Bacaplermin but also had lower extremity ulcers. And then the columns on the right are just showing the survey sample. So the patients were matched on a number of factors, and they were similar in terms of most variables. The only differences that we identified with what we measured, which remained, were that they tended to have more severe diabetes with more complications. They also had more recent utilization of services. They were in the hospital more often. They also had evidence of more severe ulcer characteristics, more aggressive treatment, and wound care measures. We had several hundred variables from the rich VA database. These were all adjusted in the multivariable Cox regression. And in addition, we used the variables from the survey. So our final results showed very comparable numbers of cases in the Bacaplermin group and the comparison group, and estimates of risk very close to 1, indicating no increase in risk for incident skin cancer or other cancers. And if we broke it out by cancer type, we found a bit of variation, but again, no evidence for increased risk in various cancer types. These are the Kaplan-Meier curves showing events over time, and they're almost entirely overlapping, again, consistent with no evidence of increase in risk. This is the dose analysis. So, again, at the 3 or more tubes dispensed for skin cancer or other malignancies, that bottom hazard ratio in each of the boxes is below or at 1, again, consistent with no increase in risk. We also looked at a large number of pre-specified subgroups, those on insulin, those with prior amputation, those who were exclusively VA users, and there was no evidence of increase in risk. So just shifting to the cancer death rates, cancer death risks in the total sample, we again found no increase in risk for cancer death, either overall cancer or by type, largely overlapping Kaplan-Meier curves. No effect in subgroups, and then the analysis by doses on the bottom, which is the one that was most important because we were trying to address the signal from the first I3 study, and our estimate was very close to 1. Their estimate of 5.2 was based on 4 cases. Ours is based on 67, and a bit more rigorous design with a lot more information on potential confounders. So in addition to the rich information we had on confounders, we were still concerned that there could be unmeasured confounding, that is, things we didn't have information on. So we used an alternative method called instrumental variables analysis. The instrument is the Kaplan prescribing rates at facilities in the VA. This has the promise of adjusting for unmeasured confounding, and again, it didn't change the conclusion, which is that there was no increase in risk. And then finally, we looked at, we were addressing the question of whether application could have increased risk of skin cancers at the site of application. So we looked at skin cancers at the lower extremities. There were small numbers for malignant melanoma and basal cell carcinoma, similar between the groups. For squamous cell carcinoma, there seemed to be more in the Kaplan group. So at the site of foot ulcer, it was 10 cases versus 4. It was not statistically significant, but we reviewed all the charts, and 5 out of 10 of the Kaplan charts labeled it as verrucous carcinoma, 0 of 4 in the comparison group. So verrucous carcinoma is a well-differentiated form of carcinoma with low metastatic risk. It's a difficult diagnosis to make without a deep biopsy. So in review of the charts, we found several of them saying that the cancer may have been present at the time of treatment, so the Kaplan may have actually been applied to the cancer at the site of the carcinoma without apparent harm. So for this and other reasons, we feel this is unlikely to be a causal association. So our strengths and weaknesses. It's a large sample, long follow-up, cases were confirmed. We have rich confounder control and have tried to address confounding in a number of ways. Our limitations are it's a study of veterans, mostly men, and we were basing our exposures on tubes dispensed, so we really don't have precision in terms of how much was actually applied at the site. We could have missed cases of cancer, but we feel it's unlikely. And there could have been residual confounding. Again, we feel it's unlikely. One limitation is that we excluded those with prior cancer, so we can't address the question in this study of whether the Kaplan increased progression of cancer or in those with pre-existing cancer. This is labeled specifically, mentioned specifically in the warning label of using caution in patients with known malignancy. So we conducted a second study asking the question of what are the risks of Kaplan use in those with prior cancer in terms of accelerated cancer progression, earlier cancer death. So we went back to our original sample, pulled out those who were excluded from the first study, and identified those who had a first diagnosis of cancer within 3 years of the index date, or the date in which they were given the Kaplan, and then matched those 4-to-1 to a sample of those without the Kaplan who had the same conditions. And our final sample with the 3-year look back was 477 compared to 1756. You can see the numbers coming down to within the past year. So we again did a multivariable Cox regression, but in addition to all the variables we had in the first study, we adjusted for cancer type, time since the cancer diagnosis, some measures of cancer treatment and oncology service use, and also life expectancy, which we estimated from aggregate data from SEER and NCI and the American Cancer Society. And the results are shown here, which is the actual estimates were below 1, but all of them essentially consistent with 1, showing no evidence of increased risk. In addition to this analysis, we conducted a number of others just to check our results. So if the Kaplan patients were sicker, they may have died from other causes before they would have been available for a cancer death. And this is a classic competing risk problem. So we did a competing risks analysis, which takes it into account. This didn't change anything. We did the instrumental variables analysis. That didn't change the conclusion, nor did looking at the high dose use. So this summarizes all of the studies we've done and all of the available evidence that has been published on human data on cancer risks from the Kaplan. You can see that the amount of information coming from our study and from the I3 extension, the preponderance of evidence is for no increased risk for cancer. I think these results are extremely reassuring and should address some of the concerns from the warning label. So our results should have implications for other PDGF-based therapies, a couple of which are on the market, but it's going to depend upon dose duration and how much is absorbed systemically, and they need safety studies as well.
So if anyone has questions, we'll entertain your questions now. So her question was if this was recommended for people that don't have diabetes, that have an ulcer from some other etiology, and it's not approved for that, and it probably won't be paid for that unless you're in, unless you get prior authorization.
I mean, have there been any studies done on any other types of wounds?
Yeah,
and any other further studies since '98?
Yeah. Again, since this is CME, we can discuss these. And, for instance, there was another study I think that's really important because a lot of people have issues with the BID wound care. And remember, the reason we have the twice-daily wound care is because that's how the pivotal trial was done, and so that's what the package insert says to do. But MBIL did a study published in Wound Repair and Regeneration published back in 2000 where he and the other authors replicated the Weeman trial, but it was an open-label trial. They didn't have a control group, but they replicated it, and what they did is they just applied Bacterial, a non-adherent contact layer like Adaptic and gauze, and just applied it once every 24 hours, no second dressing change, and they actually had a healing rate of 57.5 at 20 weeks. Now, again, that's not randomized, but it gave us more information about, well, what would happen. And in fact, their time to healing was 9 weeks. But it has also been studied in pressure ulcers. It was a very small trial published by Reese. 124 patients, 4 dosing groups. Well, actually 3 dosing groups, 1 placebo group. So there was like 30 patients in each group. And it did show at both the marketed dose as well as a higher dose a statistically significant improvement in healing of pressure ulcers. It was a phase 2 trial. They never went anywhere else with it. And so again, and I don't see them doing that. I mean, that would cost a lot of money to be able to do large randomized controlled trials with other etiologies. But we're seeing that with other growth factors. Other growth factors are being tested in venous ulcers and other types of wounds. And so this is just the beginning.
We have a few questions from the web audience. Could you comment on the current state of synergistic improvement of healing when combining PDGF therapy with HBOT?
There is a paper. It was published many years ago showing that hyperbarics may upregulate receptors for PDGF on cells. So if you have more receptors, the PDGF can bind to those receptors. Is there clinical data? No, there is not.
Well, good. Thank you very much. I appreciate your attention.